Okay, I'm going to get started. So welcome and thank you for joining us. This is session 4A, Scene First. My name is Michael Roach and I'm the moderator for this session. Before I introduce our speakers and we start the session, just a couple of reminders. You can increase the size of the slide presentation by right-clicking on the presentation image, selecting picture-in-picture, and resizing the pop-out window. During the presentation, you're welcome to put your questions and comments in the room chat, which you can open by clicking the chat icon at the top of the screen and selecting current room. At the end of the presentation, you'll also be able to ask questions using your microphone by raising your hand. Now I'll introduce our speaker for the session. Julie Samson graduated from Ottawa University Medical School in 1995 and completed her family medicine residency in Northern Ontario and her emergency medicine certification in 1998. She began her family practice in Timmins, Ontario in 1999, where she also works in the emergency department and as a hospitalist. She also works part-time at a local shelter primary care clinic. She is actively involved with the opiate crisis in her city, advocating for better access to and improved care for people living with addictions. As co-lead of the addictions program at her hospital, she works with the Acute Medical Withdrawal Management Service Addictions Medicine Consult Team and Community Withdrawal Management Service. Julie also works in outreach addictions clinics in communities along the James Bay coast. Louisa Marion-Bellemare completed her medical residency at the Northern Ontario School of Medicine. She works at the Timmins and District's Hospital Emergency Department, Pediatric Mental Health Department, and the Addictions Clinic in communities along the James Bay coast. Louisa can also be found working at the Indigenous Healthcare Centre and the local provincial jail. She is the addictions lead for the Ontario Health Northeast District. She is the co-lead and works with the addictions medicine program at the hospital, which includes the Acute Withdrawal Medical Unit, Addiction Medicine Consult Service, and the Community Withdrawal Management Service. She is actively involved in her community by promoting barrier-free access to addiction treatment with the ultimate goal to save lives and improve quality of life. Seamus Murphy is Deputy Chief of Standards and Community Services for Cochrane District Paramedical Service. In 2020, CDPS became the province's first ambulance agency to distribute naloxone kits. Seamus was instrumental in sharing this knowledge with 25 paramedic services and base hospital programs throughout Ontario. After 2 years of lobbying the Ministry of Health, he received approval to create a medical directive for the province and partnered with Timmins and District Hospital Withdrawal Management and Addictions team. On May 1st, 2023, the community paramedic program led by Seamus started treatment for opiate poisoning on scene with buprenorphine naloxone after the Ministry of Health extended its approval to all ambulance services in the province. The CDPS became the first in Canada to have every ambulance and paramedic response unit in their service equipped with buprenorphine naloxone. Vital to this advancement in care, Seamus continues to create efficient process and educational resources for Ontario-based hospital groups. And now I will pass it over to our presenters.
Hi, everybody. Thanks for having us.
This is Louisa.
I'm Louisa, Julie, and that's Seamus, not Seamus, Seamus.
And your camera's off, by the way.
Oh, our camera's not off. It shouldn't be off. Can you not see us?
Oh, that's where we can see each other. Okay, well, we'll just talk anyways.
That's right.
Can you see us, Michael? Can people see us?
Your screen.
You can see us.
Okay.
Okay, that's
perfect.
Anyways, thanks so much for having us today. We're going to talk about something that started out as a pilot project and now is fully implemented in our community. This is where now all the rigs in our community are equipped with buprenorphine naloxone. And when someone is fully reversed from naloxone in the field in our community, typically bystander naloxone, and EMS arrives, that they can then distribute Suboxone or buprenorphine naloxone. We're going to talk about that today. Next slide.
So this program has not received financial support in any form. This program has not received in-kind support from any organization. Cochrane District Paramedic Service, CDPS is division of Cochrane District Social Services Administration Board, and all funding and education has been budgeted annually. our paramedic service considers these directives created to help treat the harm reduction community a part of our regular duties, and we have no potential conflicts to declare. So I am presenter Seamus Murphy. Relationships with any financial sponsors, I have none.
And on behalf of myself and Julie, these are our relationships with sponsors, and currently we have no consulting fees at this time. Next slide.
So our mitigating potential bias, there are no sources of bias nor potential bias, with apart from my two friends, Louisa and Julie, giving me the opportunity to provide scene first treatment to those in need. Contents, reports on clinical experience and such includes off-label uses.
Right, so the objectives today, we'll review the medical directives for EMS buprenorphine initiation in the field. We'll discuss the clinical and administrative considerations involved in developing such a program, and we'll consider opportunities and challenges that we had doing this program as well. Next. So when we first got started, and we'll go through this in more detail, but Lou and I, when we thought about this and approached Seamus, there's a few things that came up that, were these are going to be quick challenges that we came up with quickly. The geography of our district, the addiction programs for follow-up that aren't available and running in every city, the fact that EMS has to go to a hospital, can't bring patients in other settings, possibly patients refusing to take on this buprenorphine treatment, which is life-saving. How are we going to handle that? Patients refusing the dosing we were offering, and also one of the big challenges was, somewhat convincing our emergency department-based hospital physicians that are involved with the EMS that this could work. When it was first brought up, they wanted evidence. They wanted, and the big questions was, would this keep these patients out of our emerge department, and will it keep my paramedics on scene too long? Because that was the one thing that they felt was important to know. Interestingly, they don't ever ask that about chest pain, but they were asking that about our poor patients that have sustained some overdoses. Next slide. So as you know, Timmins, Ontario is a Northern Ontario city, population about 42,000. That's just Timmins. There is a district area that Seamus will talk about that involves our paramedics. It's about 8 hours north of Toronto, and it's home of several people that you may know: Shania Twain, Bill Barilko, and Steve Sullivan. But it's also the home of the LUJU. Everyone knows the LUJU. We've presented this slide before when we presented about macrodosing in our program, but now it's also home of the LUJU Shamu. So Seamus is known as Shamu here. So we're so excited that he got on board for this program, because really he led this program when we brought up this idea, and we owe everything to Shamu for sure. Next slide.
So we speak about the challenges. This is our district. So we have 141,000 square kilometers to cover, basically. But when we break it all down, we look at, these are our actual bases. So from Timmins, Matheson, Iroquois Falls, Cochrane, Smooth Rock, Kapuskasing, and Hearst, these are where all of our bases are. So for me to drive from Timmins right up to Hearst, it's about 3 hours if it's going direct. But if I have to go around it, it can be a 5-hour drive.
Oh, and that's 500 kilometers, not Toronto terms. 3 hours in Toronto could be 5 kilometers.
Yes.
300 kilometers in Northern Ontario is 3 hours.
Of nothing.
Trees.
Moose.
Oh, no, there's things.
Okay.
Moose, bear, beaver,
Yeah.
But yeah, big difference.
Right. So we're going to talk about some of the reasons why we went with what we're doing. So when you look at the opiate poisonings report, this was reported from the Chief Coroner's Office from 2018 up to 2021. So in the Porcupine Health Unit area, there was approximately 48. Now, you have to remember this is based on a 100,000 population, where Timmins itself is about 42,000. So you can see when you look at the conversion to the 100,000, Timmins was at 80 fatalities in 2021.
And the reason why there's two things about this slide I want to say. This slide in 2020, Timmins was at the top of the slide, and we were at 70.2 per 100,000 opiate related deaths. So, you know, it's awful that we are still in the top 10, but we were number one in 2020, in the beginning of 2021. So, you know, with respect to some of the interventions we've done in our community over the last 3 years, we have now moved down. We aren't at the top of the list, but we do remain 5th right now overall in the province with respect to the chief coroner's report. Similarly to the next slide, if we looked at this, there should be a little arrow that comes through. If we look at this slide, again in 2021, 2022, with respect to the Porcupine Health Unit, which includes that whole area that Seamus, the 142,000 square kilometers, we were top 3. I think in 2020 and 2021, we were 2nd. I can't remember who was ahead of us with respect to the health unit area, but again, we've moved down. But northern communities still remain the highest with respect to number of overdose deaths per 100,000 people. And we like to drive this point home, both as Julie and I, we work in the emergency department, and Seamus, as a long-term, has been a paramedic for many, many years, is that there were these guidelines put out in 2018 that talk about treatment of people in withdrawals, and that their withdrawals should be treated within 2 hours because of their high risk of overdose and death. And we know this as people practicing in this area, that people who are in withdrawal either because they can't get their drugs of choice, or because they've received naloxone, have a higher risk because they have a reduced tolerance at that time to using and overdosing and dying. So this 2018 guideline came out, but what's interesting, I don't know if there was any emergency departments in Ontario that adopted this standard or this guideline that was set out by Health Quality Ontario. And Julie and I happened to find this guideline in 2020. And we felt terrible that we didn't adopt it. So we decided as an emerge department in Timmins to adopt this, and we now treat people in severe withdrawals. And there's only so many places that we can do this. There's only so many places in our area of work that we can maintain this guideline. And one of them, of course, is the hospital. It's open 24 hours a day, 365 days a year, and we can treat withdrawals in 2 hours. But the other place is emergency, the ambulance, so EMS.
So the history of our partnership with EMS, and this is how this all kind of started. So it was actually in 2021, the North York Emergency Medicine Conference was virtual at the time. And and my husband was an emergency doc, was on the conference, and Louisa and I had started macrodosing patients in our hospital, in our emerge department. But, you know, it was all still quite new. And this Dr. Ruben Strayer was talking about macrodosing in the emergency department, and about how it works and why it works. So I said, oh my God, this guy's doing that as well. So what we did is we set up a Zoom meeting with this Dr. Strayer, just to go over like what his thoughts are on microdosing.
And he works in New York, I think it was. He worked out in New York. So
then it's during that conversation that he said, wait a minute, he said, why are you guys so worried about this? Don't worry, you're doing the right thing. You know, and by the way, people are doing that now in New Jersey in the field. EMS are supplying large doses of buprenorphine to patients in the field. So it's safe, don't worry about it. So we're like, what? So they're doing this in New Jersey. So we looked up the study, and then we said, oh, wait a minute, we got to call Seamus to see if he could help us with this, to see if he's interested in taking on this, maybe a pilot project to do this in Timmins.
Because that was a group of people that we weren't reaching. We were reaching to people coming to the emerge. We were reaching to people coming to ask for help, but we weren't reaching the people who were overdosing, receiving bystander naloxone, who weren't coming to our hospital.
So we called Seamus, and Seamus said, yeah, you know what? I want to be part of this. So then we set up a Zoom meeting with the New Jersey group who were doing this, and the three of us. And that's when Seamus just ran with it. And he's been doing an amazing job. So this is the group that we met with, the New Jersey group, who were doing this in the field. This was a case series that they published. And essentially, patients qualified for buprenorphine in the field if they had been reversed from naloxone at a COWS over 7, if they were over 18, no methadone in 48 hours, and were not pregnant. And what they did at that time is they gave 16 milligrams of Suboxone followed by a repeat dose of 8 milligrams if needed. And what they found at that time with this case series is there's all improvement in their withdrawal symptoms, and also that they had no precipitate withdrawal, and they were all linked to outpatient addiction treatment as well. So that was kind of the case series we had to work with. But since then, there's been other published, case series or retrospective chart reviews, including this one from 2023, which was based out of, this was their study, which was a larger amount of patients that they were able to publish. And again, what they showed was patients who were given buprenorphine had, control of their withdrawal symptoms, no precipitate withdrawals, and were more likely to remain in treatment after 7 days. And then when compared to patients who were not given buprenorphine. So that was just published by the same group in 2023.
So when we look at our challenges, because when we had this idea, like we usually do, we chatted with Seamus, and Seamus said, we got to make this happen. So the first thing we said, how in Timmins can we make this happen? This was our first challenge. We need to convince a lot of people that this is a good thing and this is the right thing to do and that we're going to make a difference. Next slide. So we had to develop a partnership. So like we said, we called Seamus Murphy. He was on it. And we had a virtual meeting with the New Jersey group.
A couple.
Yeah, actually, we didn't just have one. We met with
few.
Ruben Strayer from New York, and then we had quite a few with the New Jersey group, and they were so wonderful, sharing their protocols, encouraging us. They wanted us to do this. They said, this would be awesome. This needs to be done in Canada. And then it went from there.
And Seamus ran with it.
So Cochrane District Paramedic Service was, again, the first paramedic service in Ontario to become the naloxone distributor in July of 2020. And that was a 2-year process in itself. Dr. Leanne Catton came to me from the public health unit. She's the medical officer of health for them, and lobbied with myself to Dr. Williams at the time. And it was, of course, because of COVID, we've got to give some credit to COVID because there's a lot of things that have benefited the communities because of that. Frontline paramedics will provide patients, bystanders, and the public with naloxone kits. We'll also educate them as well, resuscitating poisoned patients and leaving naloxone kits behind for those who refuse transportation. And of course, that wasn't enough. So Cooper EMS stats and initiatives revealed the benefits of paramedic services that could provide scene first medication-assisted treatment. So we did make the news, and you can see here in the picture, I'm standing with Louisa and Julie, and this is not Louisa's best side, but that's the picture that I had. And of course, the CBC, the national, walked and spent a day or 2 days with Louisa and Julie to get this known across Canada. I was in a few of the clips, but accordingly, I hit the editing room floor. But we're making an impact now. When we look at our second challenge, is this needed in our district, and what does our data show? Well, of course it's needed in our district. Here's what our data showed from 2018 to 2021. So you can see the EMS responses across the top. These are for opioid poisoning calls. So in 2018, you can see here 35, and then going up to 321 patients transported. It increased throughout, but then patients that refuse also increased. But then when you look at crew naloxone, so this is what paramedics can provide on scene, like through our medical directives. But you can see that the number was increasing until 2021, where it started to decrease. And the reason for that is because we started the naloxone distribution, and we started getting those kits out there to everyone in need. The thing that we have to remember here, though, is the percentages of patients not transported. So in 2020, there was actually 29% not transported. 2021, 23% not transported. 39% in 2022, and 37% in 2023. So that's a huge number of individuals that that aren't being transported that need treatment, opiate use disorder in the field, and keep them safe. So these are our percentages over the last 3 years: 27% that weren't transported. So they're losing out on offering treatment to those refusing transport at the hospital. So that's why we needed to get it out. So that's 261 patients that didn't have the opportunity. So we needed to bring that treatment to them, and not expect that. We have to remember, these people aren't going to come to us anymore. We have to bring it to them and give them that opportunity. We need to keep them safe. We know that if we can get more treatment, it would result in saved lives, less EMS calls, less emerge visits, improved community safety as a whole, and also the compassion fatigue for our paramedics, because we keep seeing the same people over and over and over again. And I get it, I've been there. And you lose that compassion. So we want to offer that treatment to our paramedics and let them know that they're actually making a difference for the people that are in need. So our purpose: reduce morbidity and mortality from opiate use disorder by offering that buprenorphine treatment on scene, and schedule a follow-up appointment with withdrawal management services after reversal of opiate poisoning from administration of naloxone, should the patient refuse transport to Timmins and District Hospital or any other respective receiving facility along our Highway 11 corridor. So when we look at our actual opiate-related deaths for our call volume, 2017, 2, 2018, and it keeps increasing. Now, when I was on the cars, I was still an active paramedic in 2016. I could count on one hand the amount of opiate overdose calls I had in my whole career. And now it's on the weekly. And these are fatalities. And when you look at all these numbers, people need to remember that we can't necessarily associate homelessness and opiate use disorder in the same grouping. Out of all of those fatalities, there's 97 there. Only one person was homeless. So that's something that we need to consider. The other thing is these are what I was able to access. In the actual coroner's report, there was 40 fatalities in 2021 and in 2020 as well. So EMS isn't called for every single fatality, because sometimes we're unaware if it had any sort of opiate-related injury or fatality there. When we look at our 2022 opioid calls, you can see here in the graph, the black solid line is our average calls per week. So that's 4.6 calls per week. In 2021, there was 6.1 calls per week. And the bars across the top, that's when we declared, and we do this in corroboration. There's a group, Timmins Area Drug Strategy Committee. We determine, like all the emergency services as well as the health unit, determine whether we declare an opiate crisis, red alert, yellow alert, or we go back to a regular status. And there's certain criteria. And when you look at the yellow graph in the middle, that's our calls that week. So you can see that it's quite up and down, but the blue bar across the bottom, those are the fatalities. In 2022, these are our monthly calls for opiate groupings into months. So there was 240 calls there. 74 patients refused transport, and we at that time had 20 fatalities noted within our own data. 2023 thus far, so that's the calls per month. There's been 152 calls up until the end of August, so that's accurate until the end of August. 18 deaths that we're aware of. Now, we have to remember this is all preliminary data, and until the coroner's report comes out next year for this year, that's when we get our true accurate numbers, because these are only estimated according to our 911 call volume. Louisa?
Okay, thanks. So when we go to our next challenge number 3 is, if we were really going to do this, move this forward, we finally convinced people it's the right thing to do. We need to do this. We need to now provide treatment to a group of people that were otherwise not able to provide treatment to. The next is we have to develop medical directives to make this work, right? So number one is we reviewed the New Jersey group medical directive, and we thought it was pretty damn good, actually. There were a few things that we felt we wanted to change slightly. Number one is pregnancy was a contraindication in their protocol, and we felt pregnancy wasn't. As we know, buprenorphine naloxone is very, very safe in pregnancy. There are lots of studies out now, and we feel that if someone who's expecting is reversed with naloxone, that the worst thing for them to do is go out and use again or have terrible withdrawals. So we have included them. Then we went on, next slide, please, Seamus. We went on to California Bridge. So California Bridge also adopted this actually initially in their emergency room before it went on to their EMS. California Bridge is an excellent resource. And we actually met with the California Bridge group too. So we met with, you know, New York, New Jersey, and we met with the California Bridge group, and they were so helpful also. And mostly what they were doing was macro dosing after reversal from naloxone in their emergency department. So if somebody came in reversed on naloxone, they would start with 16 milligrams and give another 16 milligrams. So they were giving 32 milligrams within an hour in their emergency department. Then what they decided to do is go on to adopt their own emergency medical services. So paramedics, similar to what New Jersey did. And essentially they use the same medical directive as New Jersey, and they did exclude pregnancy. So what we decided to do is we took all those protocols, we sat down. This was a lot of work. We met with lots of people and went on to decide what we were going to do. So next slide is not me. Yeah, I think it's Seamus.
And here's our protocol.
Here's our, and this is what we came up with.
Yeah. So this is our flow chart for that we created and shared with with my staff, my paramedics. So the exclusion criteria. So anyone willing to give their name, date of birth, have to be 16 years of age. No methadone in the last 20 or 72 hours, and they have to have a good mental status and able to consent. If so, then yes, we can offer. We check their COWS. So if their COWS scale is 8 or higher, then we assess them for buprenorphine naloxone. So then, if they agree to it, we give 16 milligrams, and then we reassess in 10 minutes. And if the symptoms persist, so if their COWS is still 8 or higher, we'll give them another dose of 8 milligrams. And we always want to encourage them to seek help at Timmins District Hospital. So this is and follow up with the addictions withdrawal management team. So this is something that we kind of created, and of course we can't force anyone to go to hospital or follow up. But the thing that we had done was we created our own kind of withdrawal management directive. So this is the actual directive that we shared with the province. This was the dosing and everything, and again followed with Louisa and Julie, and included Dr. Chris Loretto as well, who is our medical director for our community paramedic program, and got him on board with this. And we submitted this all to the province as well. So we took the COWS scale, whether the patient received naloxone prior to us getting there or given by EMS. We evaluate their COWS to see if the patient meets the criteria for buprenorphine naloxone. And the reason we did this is we look at the simplified.
Yeah, just to make it easier too, Seamus is doing a lot of education with his staff, and we're really trying to get the staff to recognize, kind of the hard signs of withdrawal, right? To simplify it, so and with time they'll get better at this, and they'll almost be able to predict that it's a COWS over 8, right? So we're really trying to stress the importance that the patient, in severe withdrawal should have like the excessive yawning, the sweating, the tachycardia, dilated pupils, runny nose. So those hard signs of withdrawal that they'll be able to identify quite quickly, and they'll get better at this, just like we have. We know when someone's in withdrawal now, right? Yes, we can do the COWS, but we can predict it's going to be over 8.
So the medical directive, so this is what the province came up with as well. because we had to submit this. And the reason why we went with the 24 milligrams versus 32, it's always the Canadian approved guidelines. So with our help, the base hospital group has come up with all of these directives, but these were basically what we created for them. We also had to go through, there was many hoops I had to jump through to get this approved at the provincial level. And of course, everything we do, it has to do with coding. So we had to create the procedures and medications added into our coding to be province-wide. So it's a long path, and I'll explain a little more in the next slide or a few slides. But these the forms of buprenorphine. So we decided to go with the film form, and that was, of course, suggested by Julie and Louisa, because it's quicker absorption. And that's the thing. In the field, people don't want to stick around. Once they're reversed, they're in severe withdrawal. So let's get something into them and offer it to them that will absorb faster. And when we actually look at the costs of this, it's minimal. Per 8 milligram film, it's under $6. So, it's something that we can easily budget for.
And the film, everybody, anyone who's ever had it tells me it tastes better. They say it tastes more like a margarita, whereas the tablets taste like dish soap. That's the rumor on the street. So we went with film. Yeah. We like the margarita taste better.
Of course we do. So our start date was May 1st, 2023, and we did that through our community paramedic program. There were a few things that had to be done. So we did the considerations with transport of the patients to addictions medicine clinic at the TDH MHU outpatient, because when you told patients that, yeah, I'm going to bring you to the hospital, they didn't want to go because they thought they were going to have to go and wait in the emerge for hours and hours. But of course, Monday to Friday, 8 till 4, we could bring them to the back of the hospital. They can be seen and assessed by the withdrawal management team right away. The one problem that we do have still is to transport on the Highway 11 corridor. So Matheson to Hearst, there are no services set up yet. So we have to bring them to the closest emergency department. What we also set up was a notification system through our dispatch center. They'll notify as soon as we say, yeah, we've given Suboxone, they notify, of course, during Monday to Friday, 8 till 4, they'll notify the withdrawal management team during the week, and anything after that, they'll notify the emerge and let the docs know that we're coming in with a patient that's been given Suboxone. Sorry, buprenorphine. What we did with the clinical withdrawal management team is we had them create the flow chart so that they're aware, so their whole team is aware of their processes. So we're going to bring the patient to the back unless they need medical attention for something other than treatment. If they're walking, talking, no issues, we're going to bring them to the withdrawal management team at the back. But if they do need medical attention, like chest pain, abdo pain, any sort of trauma to the body, we will bring them to the ED, and then they'll be treated from there as well. Challenge number 4: convince EMS, and that's not just my EMS, all EMS. So every paramedic service across the province. So how do we do this? Education, education, education. So opiate agonist therapy, buprenorphine naloxone, should be started as soon as possible in patients requesting help. It helps treat with the withdrawal symptoms, as we're all aware of, and it decreases mortality up to 70%. We need to treat patients with addiction like we would anyone else presenting with a life-threatening medical illness. Some of the things that I incorporated and told my paramedics is, I asked them the simple question: why'd you get into paramedic? Why'd you get into the health field? I got 2 common answers. One was to make a difference, and the other was to help people. So who do we determine who we help and who we don't? Makes them think. it's something that we have to remember, is that everyone should be treated the exact same way we would want to be treated. And when you get that line of thinking, the compassion fatigue goes away. That empathy fatigue goes away. Challenge number 5, Ministry of Health application. So this is where the struggles began, unfortunately. I thought it was going to be easy peasy doing it the right way. So I went to the Medical Advisory Committee for the Ontario-based hospital group. I created a business case and proposal of buprenorphine naloxone pilot that was given to the MAC chairman, Dr. Jason Perpick, who is also my medical director for Health Sciences North. He is our medical director for all paramedics in our region, and he presented it to the group in July of 2022. OBAG accepted the proposal and wanted the buprenorphine naloxone medical directive to go province-wide for every paramedic service to access, which was to be released in February of this year. That didn't happen. We were the first paramedic service in the country to provide the treatment suffering from people with OUD, but we had to do it through our community paramedic program. And I'm not going to bash the Ministry of Health. They're just like everywhere else. They have staffing issues, and you know, there was a big flow through of staff, and somehow this pilot got lost in the shuffle. And again, I don't blame them, but what I had to do is I had to go and meet with MPP Tibolo and MPP Peary, who is our local MPP, and met with them to discuss this. They gave me 3 minutes. I talked for 37 on the importance of why we need to do this in our community, and they were in full agreement with it. But while I was doing that, my paramedic chief called our assistant deputy minister, Susan Picarello, to notify her that, you know, Seamus is gone and doing what he's doing. And she was not even aware of the proposal that was submitted by Base Hospital Group, nor myself. So again, lost in the shuffle. But because of this, we started it through our community paramedic program. And the reason I always put this is my saying, a life saved today could be a life changed tomorrow. And use it, take it, spread the word. The reason why I say this is because of my niece. My niece died of a fentanyl overdose last year. Last April, she was found obviously dead by her father. She lived in New Orleans. And in 2017, she moved to Timmins. She came here to try and clean herself up. She was prescribed an opiate years ago when she was 14. She was 26 when she died. Prescribed an opiate for a fractured ankle. She had an open fracture because of a trampoline incident. But again, there is addictive tendencies in our family, and what happened was she kind of really liked the opiate, and down the line, she was at a party and they put the candy bowl out, and everybody dumped their pills in the candy bowl, where she found Percocets or Oxys or whatever, opiate, and she became hooked. Now, she came here to try and clean herself up. Within a day, she found a dealer, an opiate dealer, and got hooked right again. Our crew saved her twice. And back then, I had the ideations of, I was the old paramedic. I was it was the tough love. It was the, you're enabling. We're not enabling. We need to do the love. We need to treat with opiate agonist therapy. You can't quit cold turkey. She tried, didn't work. She was lucky to be alive as long as she did. And the thing about my niece was that she became a peer counselor. She actually went on Suboxone. She got her, but her mother, like my sister tells me, she had to drag her tooth and nail to get her into treatment. She never ever wanted to go, which is frustrating. But she got onto Suboxone treatment, and she was clean. She was clean for a year and a half, and she had a 3-year-old daughter. Everything was going well for her. She was in University Tulane taking nursing, so degree nursing, peer counselor. She was starting a new job, but something triggered her, and she used a loan. And this is another thing, is that, you know, we really have to boost these safe health injection sites. People don't realize the amount of lives that are lost because these things aren't there. Like in Timmins alone, and we're at risk of losing our safe health site at the end of the year because of lack of funding. And I'm hoping somebody here from the ministry or someone with any sort of pull can hear this. There's 130 people that overdosed in the last year at the safe health site that was prevented. That's 130 people that would have died using a loan. And because of the safe health site, these are the reasons why our EMS call volume is dropping. And the cost to the taxpayers is dropping. So I'm hopeful that some people here have a little pull for us and put in a good word for the safe health site Timmins, because it's needed, and there should be one in every community, especially when there's an opiate crisis right now. But anyway, I digress. I will move on to the next slide. We will share these slides, or we have shared these slides. So these are treating on scene equals better outcomes, and these are some of the interviews that happened with CTV News that I had. You know, feel free to look at those after. I don't want to take too much more of everyone's time because we're running out of it. But some of our EMS specific data, so patient demographics, including age and sex, naloxone administration, dosage, and by whom, the COW score, pre and post buprenorphine treatment, total dosage. So these are all the things that we're looking at, and then recurrent EMS calls for patient recently treated with this directive. So is there a 7-day interval and 30-day interval? So some of our results thus far. Again, we started May 1st, 2023. We've administered buprenorphine naloxone to 16.67% of our opiate overdose patients. So out of all of our opiate calls, we've administered it 16%. We were initially expecting 1 in 10, and so 10%. So we're ahead of the game so far. 67% of these people were transported to TDH. 33% refused transport or left against medical advice upon arrival. But 17% of the people that we've treated out of that, so that's 16.67%, 17% have gone into long-term treatment. And that's with the team. So they've gone into Suboxone, the Sublocade injection, the long-term sub-Q injection. Average on-scene time. So that was, so our on-scene time now is 16 minutes and 54 seconds. When it was, before this, 15 minutes and 51 seconds. So a total of 1 minute and 3 seconds difference. So for 1 minute and 3, we're getting Suboxone into individuals. We still have a 12% fatality rate in our area. And again, this is all of our own data. So Louisa.
Thank you. So again, you know, most of us here today are the yayers. We know that this is important and it needs to be done. Seamus and I presented to the Ontario-based hospital group in Sault Ste. Marie. We drove to beautiful, I should say flew in Seamus's truck to beautiful Sault Ste. Marie and did this presentation trying to convince paramedics and based hospital group physicians that this is important and that we think all EMS services across the province should be doing this. But we know that immediate access to evidence-based life-saving treatment is why we need to be offering it in the field. We know that if we offer it in the field, it's a portal of entry. We're literally giving people the taste of a life-saving medication. If, you know, we always say this, people say, well, they never want to stay in treatment. Well, if we don't offer them treatment, they can't stay in treatment. We need to be there to initiate treatment for our patients who otherwise we don't see or never will see. We know the long-term benefits if they remain on treatment. So we need to start them and give them an opportunity for them to have treatment. Next, is it going to go? Of course, there's a decrease in EMS calls, which we've shown in our data. There is a large percentage of refusal to the hospital. So that's what was part of the drive for us to do this. Is there was a huge group of people reversed on naloxone that were never coming to the hospital, so they would never get treatment. Because of that, now, even if they refuse to come to the hospital, we at least can offer them a treatment. It decreases compassion fatigue. And of course, we always say they can't remain in treatment if they're not offered treatment.
So we are redefining the role of EMS in the opioid crisis. And as you can see, we started with the naloxone dispensing and distribution, as well as now the access to medication-assisted treatment, so the MAT. And that is the end of our presentation. Any questions? I'll let.
I love this picture. I asked Seamus for a picture for the slide for the Louisa Shamu, and then he sent me all these pictures. I'm like, these are going into this presentation somehow.
Great job presenting, by the way, Seamus.
We're just the cheerleaders this time.
Way to go. Good job.
Thank you. Thank you. Couldn't have done it without you.
Okay, thank you very much for that wonderful presentation. I'm going to open up for questions now. So I've allowed the audience members to be able to unmute themselves. So you can either raise your hand to ask a question, or you can put it in the chat. And right now I see one question. So has anyone considered having overdose prevention and safe consumption sites enabled to give buprenorphine for patients who receive naloxone in their setting? Of course, medical directives would be a hurdle, but imagine potentially engaging 17% or more of people using the SCS program.
Yeah, so the safe injection site, interestingly, there's overdoses there, but I think they've given naloxone once. Right, because they usually support them. They don't fully reverse them, because we know if they do, there's potential of them using and overdosing again. So they often will just support them with oxygen, a bit of a pressure bag valve mask, and that's about it. So we've never had to give naloxone in the safe injection, I think once. But we do, our safe injection site in Timmins, the hospital's a lead operator. So often we get calls. Some of our nurses that work withdrawal management also work the safe injection site. So if a patient wants help, we do go there and we'll start help there. Or we bring them into our withdrawal management unit. We give Sublocade at the safe injection site. So if our patient we don't know where they are, then they end up going there, we go there and give Sublocade as well. So if they were fully reversed with naloxone, which they wouldn't be in our safe injection site because we use small doses like EMS and Emerge, but if they're fully reversed, for sure that'd be something that we would be willing to do.
And we have to remember too, Julie, that what was there, 44 or 50 patients that were going to the Safe Health site that were put into long-term treatment?
Yes. Yeah. So we have patients presenting there that are requesting help. And we've had some great success stories from bringing them into our withdrawal management unit onto depot buprenorphine and still on the treatment program now. So it's another portal of entry into our system, right? Just like now EMS will be a portal of entry into a treatment where often there's barriers because of time of the day. You can't expect some of these clinics that deal with substance use, like RAM clinics, to be open 24/7. They can't, right? So this there are a lot of barriers for these patients to access treatment. So this is just another part of the pillar to allow barrier-free treatment when EMS will give buprenorphine in the field.
Seamus, I just wanted to acknowledge that Tracy thanked you for sharing your difficult experience as part of this presentation.
Glad to.
So Amanda asked, do you do this presentation in other communities?
Anyone that would like to start some sort of Suboxone treatment, like Louisa had said, she and I went to the SU last week or the week before, and we presented to all the base hospital groups. You could hear a pin drop in that room, and every paramedic service now has access as of July 10th to start using buprenorphine naloxone in the field. The only problem is that they have to get the required education from the base hospital group. I and Louisa and Julie have all been in corroboration with the lead educators with base hospital, and they are currently going to be going through the education effective, I think, next month, beginning of October, and offering it to any paramedic service across the province that wants to do it. But yeah, I will gladly present to anyone that wants to hear about it.
And we're collecting data, right? Seamus is on that. Everything's collected. I foresee publishing case series or about our program here in Canada and in collaboration with the other programs going in the States. And some of the programs in the States, I didn't go over all the data and all the details of these studies, but some are also supplying buprenorphine to patients in withdrawal, not necessarily just post naloxone. So the California group is also supplying patients, if they go to call and the patient is in just withdrawals and has not received naloxone, they will administer buprenorphine at that time too. So I could foresee in the future maybe that happening to our program when I think the paramedic service is more comfortable with administering buprenorphine post overdose. Right?
It's like them going to a call and someone has chest pain. They give them a bit of nitro before they bring them to the hospital. Aspirin. Or aspirin, or someone, is having trouble breathing, they give them a couple puffs of Ventolin. I could see them going to a call, someone's, got a Cowzo or 12, hasn't used in this amount of time. They would give them a dose of buprenorphine and then bring them to the hospital.
Or linking them to an outpatient the next day, right? Organization for ongoing treatment.
Yeah, and that's definitely the plan that I foresee, and it's going to be carry overdoses because the clinics aren't open 24 hours a day yet. We don't have the people for it. And our actual stats show that opiate overdoses happening during the day between 11 a.m. and 6 p.m. Monday to Friday.
Yeah, that's right. That's why our safe injection site, our safe consumption sites, we call it safe health site, is open from 9 to 9 because our data showed that, right, Seamus, that most of our overdoses are occurring during that time.
And one of the challenges, and Seamus, you can speak to this, is that, let's say EMS in the future, everyone's doing this. Like right now, an ambulance is not allowed to bring a patient to an outpatient clinic that's not associated with a hospital, right, Seamus?
Right now, unless they create a treat and refer program, which I had done, but because our withdrawal management team was at the hospital, we were allowed to kind of bypass that. But I can't just take a person, I can't go to a call, pick up a patient and say, where do you want to go? That's not how it works yet. Soon, as long as we create the partnerships with the RAM clinics, with any sort of other withdrawal management services. But I went with who I knew and who I trusted, and that's Timmins and District Hospital, Louisa and Julie, who are the leads of this team.
Okay, another question. So speaking of withdrawal management, this is from Tristina. Thank you. This chat was awesome, and I'm in the withdrawal management safe bed at Sault Ste. Marie, so I really hope they consider adopting this soon. I'd love to see the algorithm in more detail regarding the transfer from EMS to WMSB. Withdrawal management safe beds. It wasn't necessarily a question, but if I'm reading between the lines, I'm assuming people want to know how to get in touch with you.
Oh yeah, so we didn't put our emails on the slide. Usually we do, but
oops, sorry, we forgot. We usually have our emails at the end.
So Michael, I don't know, we can just share our emails, I guess, in the when we send the slides in our presentation or something. I don't know. What do you suggest, Michael?
Can we put it in the chat?
Yeah, you can put it in the chat. I know that's what some other people have done, or yeah, whatever you're comfortable with.
Yeah.
Put it in the chat. I'm not sure I can do that.
Yeah, that's too complicated for us, Michael.
Fair enough.
We're afraid to touch anything and mess this up.
You know, I thought about that when I was looking at it this morning. I'm like, nobody knows our email addresses.
Yeah, usually we have it. We forgot.
You know what? I'm going to put, if you guys are comfortable with this, I will put my email in the chat. And
Perfect.
I can always forward it to you guys.
Yes. Yeah.
Lovely.
Perfect. Thanks, Mike.
No problem. Okay, so next question. This is an amazing intervention. I'm curious the on-the-ground experience of those who take the buprenorphine and then refuse to come to the hospital. How many do you think are showing up to another provider to continue?
Oof.
Yeah, I don't know what the refusal. Do you know what the refusal? Well, you do know what the refusal. You're keeping stats on that too.
Yeah.
And I think that's our next step, Seamus, is getting community paramedicine more involved in the sense that the people we offer it to, trying to follow up with them the next day. That's our work, Seamus?
Yeah. So anybody that that accepts treatment but refuses to the transport, what we're going to be setting up is we can refer to ourselves so the EMS side can refer to our community paramedic side. And what'll happen then is that the community paramedic, first thing in the morning or noonish, depending on what the users, the person is suffering with opiate use, what time they wake up. But we'll follow up with them and do kind of an outreach. See, go up, ask them, how are you feeling? Do you feel normal being on Suboxone? Do you think you would want long-term treatment? Because we want to be able to offer that to those people because they don't want to go. As soon as we get to them, they don't want to go. I was even talking with some of the RAM outreach in Ottawa, and what they'll do is they'll give takeaway Suboxone to their patients to get them through until the clinic's open. So that's something that we're really looking at.
Lots of thank yous and kudos in the chat. So this is a longer comment from Leslie. So this is such a wonderful intervention. There are other great things mentioned. Having immediate access to addiction treatment as an option instead of the ED. It's also great to see connection between supervised consumption site and treatment.
Mm-hmm. Yeah, for sure.
And we're lucky because we have such a small community. And we're also easily interconnected, that for us, it works really well because we understand in bigger communities, this is much harder to do, but I do think there's ways around it, and we're fortunate because our community is small, but there are ways to make it work.
And you need a Seamus. I'm telling you, you need a Seamus to do this project. He's amazing. And we knew it. That's why we called him. We knew he'd be on board.
Mm-hmm.
Speaking of Seamus, I see he was able to put his email into the chat.
So okay, let's see. We're going to try. Oh, where's the chat box? Okay, guys, we're going.
Well, as long as you have Seamus, that's all you need. You need Seamus. Yeah. He has all the algorithms. That's okay. And then if we need to get involved, he can forward it to us. And
yeah, Michael, I just emailed you and CC'd Julie and Louisa's email in there. So yes, reach out to me, but if you want to talk medical, talk with those two. I'm just a dumb paramedic.
I know. I love it. He's like a go-getter. He's so good.
So there's some people who are saying everyone, so Tim says everyone needs a Seamus.
We could change the title of the presentation to that.
Oh my God, we should. That's perfect. We're on it. We're on it.
On the Seamus clothing program, you're going to need a whole lot of material. I'm 6'7", 325 pounds.
His hands are huge.
If you invite him, don't bother serving vegetables. He doesn't like them.
I'll eat them. I'll eat them. But yeah, you don't get a physique like this eating vegetables.
So if there's no further questions, it is 11:30. So I just want to thank you all for your wonderful presentation. I have put the evaluation link into the chat. I'm just seeing Dr. Wyman's comment. Don't forget to join the networking tables. Table topics include substance use treatment in correctional settings, community-based withdrawal, counseling in the RAM setting, challenges and opportunities to challenges and opportunities in community OAT practices, residential treatment, MPs in addiction care, building RAM connections to ED and primary care, and Medifying RAMs. This is a chance to discuss support opportunities and engagement. There will be extra tables, so please feel free to invite people to meet you at a new table or table hop. I hope everybody has a good rest of their day at the conference.
Great. Thanks, guys.
Take
Thank
care.
you
Thank you,
so
everyone.
much. Good job. Bye.